So welcome, Danny, and thank you for joining me here at BusyHive Podcast.
Thanks, Chris. Thanks for having me back.
Yeah, so great you joining us again. We had an amazing podcast with you a couple of weeks ago about cross syndrome pattern, which we talked into details and explained what. And that's why we brought you again, because there is lots of amazing subject. And today in the podcast we have amazing, really great subject to talk about joint by joint theory, which we're going to explain and talk about more a little bit later on. But Danny, because many people even haven't even listened to the podcast, maybe didn't listen to the podcast before, or just can you explain, can you give a brief introduction to yourself? Who are you and what you do?
Sure. My name's Danny Christie. I'm originally from London, England. I now live in Miami, Florida. Been here for probably about 10 years now. I own and run a small practice here in Miami. I see about 35 people a week, give or take. I do half body work, half therapy, and half like rehabilitative type training. And most of my clients flip-flop between one of two of those modalities. So it's kind of cool. I live in both worlds, like the rehab stuff and the soft tissue world too. So that's great.
Amazing, thank you. So, Danny, I'm just gonna ask you. We have like a 10 round of quick question, just kind of to start the interview, and with the different sounds, just kind of ease off into everything. So, I'm gonna ask you the first question. What's your favorite muscle and why?
My favorite muscle, it's gotta be. Well, that's a good question. Favorite muscle, probably the bicep femoris, the hamstring.
Oh, wow. Okay. Why?
Commonly dysfunctional, commonly tight, commonly weak, commonly strained, commonly overused. And it's just a very weak area of our body. Like that posterior chain is a very generally weak area. And we'll touch on why I think that is later on as well.
I think it's very, very much so, because everyone just kind of remember about big compound muscle, okay, with biceps, chest, quads, calves, glutes, and that's it. We forget about adductors, we forget about hamstrings, we forget about obliques, we forget about, lots of muscle which just, doing so much and working so much and so working so hard.
Yeah.
To next questions. By the way, how's your hamstrings?
Yeah, they're all right.
They're all right?
I stretch them a lot, and I do a lot of stuff.
Great. So when have you had your last massage session on you?
My girlfriend gave me a massage yesterday while I was watching the football, which was like a rarity. That was a rarity. That's never happened before.
Watching football and have a massage from your girlfriend.
Yeah, but that's
never happened. She's a keeper.
Yeah, that never happened. But my first real go in to pay a professional, probably about 6 weeks ago. Probably about 6 weeks ago. I tried to go at least once a month.
Okay.
I'm pretty good about going once a month, and I go to random people. Like I go to people I don't know, and I don't tell them what I do. I just turn up and pay the $100 and get a treatment, and you always learn something.
But to the random therapist, not to the random people. You don't go just somewhere.
No,
vegetable shop. Here's the £100. Give me a massage.
Oh. No, I've not done that yet. Good idea, though.
Yeah. No, it's definitely great. It's part exactly to find a great therapist you can use all the time, so he's good at it. But it's also, as you mentioned, really good to go outside and meet different people, different modalities, different therapies to give you idea, brainstorm, kind of, and you can pick up so many stuff, from it.
Definitely.
Another question: if you had a superpower, what would it be and why?
Time travel.
And why?
Oh man, if you can predict the future, you're a winner.
Yeah. But would you go to future and back, or past and back?
No, I'd go back then forward, I think.
Yeah. Cool.
I'd go back, buy Apple stocks, then come back.
Yeah. Oh, yeah. Yeah, for sure. What is the best business advice you ever received?
The best business advice I ever received. I remember when I was doing the mentorships and the teaching with Eric Dalton, I remember him telling, I don't know if he actually told me personally or was telling us as a group, but he said, when you get a client, he goes, work on the, so if you get a female client, work on the husband and like a sibling. Or, so you're trying to just not work on one person in the family. So if you, and I've done that. So I work on the husband, and then invariably I start working on the wife and then the cousin. So you stay in that loop, especially with therapists. Sometimes there's some issues sometimes regarding therapy, but if you know the husband and the wife and say one of the siblings or one of the kids of the family, it kind of keeps you relevant.
Yeah.
So I find working on husbands and wives.
Okay.
Or friends as well, friends of those people.
Yeah.
That's worked really well for me, actually.
It's definitely one thing when you're treating someone, just give them some kind of vouchers or ask them, do you have a husband, friend? Just, give them the vouchers. Come and see me. Recommend me.
I've got a family here in Miami, and I probably work or I've worked with probably 12, 15 members of that family.
Oh, wow. Yeah. Great.
And that's been for 10 years. Like I work with three of those members 3 days a week. And then I work on the husband once a month. I work on the sister when she's in town.
Yeah.
So, yeah, it's crazy.
Yeah, no, I had this couple of other families like that, but just one especially I had went to see the husband, but actually start treating the husband, the wife, the daughter, and so on. Yeah. So it happens. So what's your favorite massage music if you use one?
I very rarely, I don't use massage music, actually. I don't when I'm in my studio or in the gym where I work, there's music on.
Yeah.
I just try and turn it down. If I'm in the gym and it's the loud music, I just try and turn the music down. So I have no preference. If a client asks, I'll put that Pandora station on, but I don't have a playlist per se.
Yeah. Okay. What is the best therapy-related book you have read in the last 6 months?
Very therapy-related book in the last 6 months. This one's pretty good, actually. I just reread this.
Oh, sorry, So who listens on the podcast is Dynamic Body.
Yeah, it's Dynamic Body by Eric Dalton.
Yeah.
There's Dynamic Body 1 and 2, I believe, but this one is really good. It's called Dynamic Body, Exploring Form and Expanding Function. That's a great book.
Great. We're going to put some links below. And who do you admire in massage world?
Well, there's many people. Like, you got people like the real research people like Gil Headley and Robert Schleip. Like, they're the real research type people from the fascial world. Then you have the practitioners like Aaron Matthews, Art Riggs, Tom Myers, and you have people like Eric Dalton, Judith Delaney Walker from the Neuromuscular Therapy Center here in Florida. So yeah, there's a lot of people actually. In Florida, there's a lot of people actually.
Brilliant. What's your favorite massage oil brand if you use one?
Wow, that's a good question. Do you know what I actually...
Oil, cream.
Do you know what I use? I don't know if we have it in England, but there's a cream. It's called Burt's Bees.
Okay.
Burt's Bees.
Yeah.
It's a hand salve.
Yes, yeah.
I use that, and one little tub probably lasts me about 6 months. It's like $8.
Oh, wow.
So that's what I use. And again, unless a client has a particular suggestion or a recommendation, what they want, they supply the oils. But that's what I take if I'm going to a session.
Okay.
That's what's in my bag all the time.
Yeah.
Hand salve.
It's good for your hands.
Yeah.
What would you say to younger yourself?
To a younger version of myself. As a massage therapist or a younger version of me? Just generally?
Generally.
Just do more, be more. Like, do what you want to do. Like, don't live in the constraints of like society. And to be fair, I did do that a little bit, but now I don't really. I think I've broken away from those sort of like barriers that we put around ourselves. Like, oh, you're X now, you need to do this. Now you're this, you need to do that. Now you need to get a job. And now you need to do this.
Yeah.
So I think just like follow your passion, I guess. Like, don't do what society deems to be correct.
Yeah.
as long as it's legal.
Yeah. Obviously. Obviously. So the next question: which social media do you prefer and why?
Uh, for work related stuff, I prefer probably Instagram, and for like social stuff, like are you keeping in contact with my family and friends back home, probably Facebook.
Okay. Do you get a lot of clients from Instagram?
Well, no, yes, no, I don't. Basically, I just started an Instagram page about 2-3 months ago. That's more for my massage teaching, and it's mainly just showing techniques, no real theory, just showing techniques
So
and letting
exposure,
people.
visibility.
Yeah, for therapy, and in the last 2 or 3 weeks, I've been getting a lot of contact from potential clients regarding those. But if you ever see these videos, they're not aimed at potential clients. They're aimed at people like me and you, therapists. Yeah. But last week on Saturday I saw 4 people actually. All on Saturday, all came from Instagram, which is kind of weird. I'm trying to work less actually, but I mean
yeah.
I should stop posting videos.
What? No. Finally, you got exposure and everything. People get contact to you, and you want to work less.
Yeah.
Yeah.
No, I'm joking. I like working.
Maybe you can expand and get some people on the board.
Yeah, that's probably that's an option for sure. That is an option.
Cool. So, Danny, yeah, thank you for, a little bit of couple of questions for fun, for, breaking the ice, just kind of to warm up before the brainstorm of really amazing theory, amazing idea. So, guys, definitely sit down, put your volume up, and, have a little bit of focus. We can always come back to this because the concept of what we're going to talk about is just mind-blowing, which is something I heard first time a while ago, and it's just something that's why we want to explore a bit more to give our listeners better understanding. So Danny, joint by joint theory concept, what is it?
So the joint by joint theory was a figurehead or spearheaded by a physical therapist here in the US called Gray Cook and a strength and conditioning coach called Mike Boyle. So during one of their sort of like coffee conversations, they was talking about this, how people fall into very predictable patterns of being stiff and being unstable. So what they devised was that the joints stack. So let's say, for example, the big toe, the hallux, generally becomes stiff. So it needs more mobility as a rule. Then the midfoot becomes very unstable. So it needs more stability. Yeah. The ankle, the talocrural joint and the subtalar joint becomes stiff. So it needs more mobility. So it goes toe needs mobility, midfoot needs stability, ankle needs more mobility, the knee needs more stability, the hip needs more mobility, the lumbar spine actually needs more stability, not mobility, the thoracic spine needs more mobility, the scapula needs more stability, the shoulder needs more mobility. The lower C spine, so you're talking C7 through about 3, needs more stability. And the upper C spine, C1, C2, need more mobility. So as you see, it goes mobility, stability, mobility, stability. So it flip-flops between one and the other.
Yeah.
And if we look at, say, let's start at the ankle, for example. So client comes in with nondescript anterior knee pain. So they've got a knee problem. If we check the joint above and below, so knee pain, we check an ankle. You're likely to see a dysfunctional ankle, like limited dorsiflexion with knee pain. As a rule, these are generic rules. And of course, like all mobile joints need stability as well, and all stable joints need mobility, but we tend to lose certain characteristics of joints based on this theory. So with the ankle, it tends to lose mobility. So we lose dorsiflexion. This generally sends stress up the chain towards the next big joint, which is the knee. The joint needs to be stable. But if you've got a stiff ankle, the knee will become more sloppy. It will move too much because it's trying to create mobility, but that's not its job.
Yeah.
The knee is pretty much a hinge joint. There is some rotation in there with a flex knee because of the superior fib joint. But as a general rule, the knee is a hinge joint, but it will start moving too much to compensate for the lack of mobility below in the ankle. Same thing is true of lower back pain. Joe Blow comes into you with lower back pain. If you check his hip, and again, maybe not, but 9 times out of 10, you check someone's hips with low back pain, you'll find limitations in mobility. And actually, the hip is a bit different. That tends to flip-flop between mobility and stability. Same with the shoulder joint action.
In the original theory.
Yeah. They say, like, because the hip is a ball and socket joint, so it needs huge ranges of motion.
Yeah.
But if you check hips regularly, what you'll see is you'll generally see limitations in two movements. So it could either be flexion and rotation, internal or external, or extension and rotation. Normally there's a limitation on 2 of those planes.
Yeah.
So hips, so lower back pain, check hips, you'll generally find lack of mobility in hips. Same with shoulders, Chris. Someone comes in with, say, anterior delt pain, shoulder pain. They could have stiff shoulders, like glenohumeral rotation.
Yeah.
But invariably what you'll find is a lack of mobility in the thoracic spine.
Yeah.
They're not getting that torque from the thoracic spine. Coupled with the scapula. Scapulas need stability. They need to be stable.
Yeah.
But they need to be stable over a mobile thoracic spine. So if the thoracic spine is stiff and maybe stuck in like a kyphotic type posture, the scapula will start to become a very mobile joint.
Because
if you've got exactly, but if you've got a mobile scapula and you start trying to use your shoulder, there's no base because your shoulder anchors to your scapula, which anchors to your rib cage and your joints and your sternoclavicular area. So if you're trying to use a shoulder on top of a sloppy or a unstable scapula, there's a saying in fitness, they say, it's like trying to fire a cannon from a canoe. It's not going to happen. So if you try to generate power with your arms on a sloppy scapula, it doesn't work.
No, brilliant. So, and can you mention again? You mentioned this briefly. So, who discovered this theory? Who's this guy?
Was cool.
Do you know?
His name's Gray Cook, and actually, I have this book here. I don't know if you can see it on camera. This is the book. It's called Movement, Functional Movement Systems, Screening, Assessment, and Corrective Strategies by Gray Cook. Gray Cook is a guy who developed the functional movement systems, which is the umbrella for the functional movement screen and the selective functional movement assessment. And Mike Boyle. Him and Mike Boyle were like the 2 guys who really put this on paper and got it out to the wider audience. But in fitness, in rehabilitation, this is getting pretty popular, pretty common. So you come in for me as a client for rehabilitation training, I think, okay, let me check Krzys's ankles. Let me check Krzys's hips. Let me check Krzys's thoracic spine. And then we devise exercises to correct the stiffness or the lack of mobility. But in the massage world, I've never really heard anyone talk about this. But it's the same. Like, we might not use exercise, but we'll use our soft tissue techniques to correct a poor ankle or a poor thoracic spine or a poor hip. Not saying it's better or worse. In actual fact, we should use both if we're allowed to, or if we're not allowed to, you liaise with someone who is allowed to. But in therapy, I've never heard people talk about this as a modality for therapy. No.
I haven't as well because obviously we learn about the different joints, different parts of the body moving, and the same as you mentioned, we learn how to do the soft tissue stuff, how to correct them, but usually tightness. Not so much with the stability. What we learn, okay, we need to mobilize shoulders and hips and ankles, but not in that kind of depth as
Yeah.
those guys go in here.
Yeah, they go very deep, and like the acronym, like what I do when I'm thinking about therapy. So if I'm thinking ankle, I want to mobilize the joint and the muscles, because with the joint by joint, you can't really separate the articular and the soft tissue. They're like, you have to do both. Like Yanda says, like you can't separate the systems are intertwined.
Connect.
So if someone comes in with let's say someone comes in with a stiff toe / ankle and they're complaining of knee pain.
Yeah.
So we go through some assessments. We check hallux extension.
So
very simple.
Big toe hallux.
Big toe, yeah. So I do the hallux or the big toe extension in a couple of positions. One with the knee straight, knee locked, one with the knee bent. So it's like, do you know when you stretch a calf and a soleus?
Yeah.
You stretch the calf and you bend the knee.
Yeah.
Same thing kind of like with the toe. You put some of the toe flex and extensors on stretch. So it gives you a little bit of a different feel. So yeah, so knee pain, someone comes in, I'll check the toe. Okay, they have a stiff toe. I'll check the midfoot. It's a bit, they might overpronate or they pronate too quick. So we want to stabilize that area. Ankle, they have no dorsiflexion or very limited dorsiflexion. The way I check dorsiflexion is you go to a wall, you go into a half kneeling position. So one knee's on the ground, one toe's on the wall, one knee's on the wall. And then you move the toe that's being stretched away from the wall about an inch. And then you move the knee to the wall.
Yeah.
That's called closed chain dorsiflexion. If the person's about 5'10", they want about 4 to 6 inches away from the wall whilst touching their knee to the wall. That's deemed normal dorsiflexion. So if they've only got like 1 or 2 inches, they're very limited. And then you want to check, or what I check is the ankle, the calcaneus, the heel. Does that heel invert and evert? What we'll see commonly is people invert a lot, but they don't evert. So then from there, so go on, Chris, you had a question?
Yeah, no, go on, carry on. I'm going to come back to something.
So yeah, so now we want to do some soft tissue work for the toes. So we might use some neuromuscular therapy, some myofascial stretching.
So yeah, about the toe, because I'm really interested, because I learned about ankles, joints, and so on, mobilization, and so on. But the toe is Can you explain a little bit more about the toe? So what do you check? You said you do how you stretch soleus, and you check the toe. Were you lifting yourself, or you actively or passively with the clients?
So let's imagine the client's lying on their back, legs straight. So you grab the foot, you stabilize the ball of the foot, and you just check, does their toe extend without moving from the ball? But what happens is, if you don't stabilize the foot, you'll push their toe up, and their ball of the foot, it's called the ray. The first ray will go into what they call plantar flexion.
Yeah.
It will move, and it will look like they have it, but they don't. And then you can bend the knee and do the same thing. Same thing, they're on their back, bend the knee to about 20, 30 degrees and check that extension of the toe again.
Okay.
Because without toe extension, how do we walk?
Yeah.
To walk, we need about 60 to 80 degrees of big toe flexion.
That's why I'm coming back to this, because we completely forget about this. Like, I now just some things popping out from the remedial course, but I just completely just blank in my head.
Yeah.
And we forget that our toe is quite important, joint in our body.
And you got to think, if the toe is lacking mobility, there's no reflective. So if a joint is stiff, let's say big toe again, hallux, it's hard for the foot to stabilize, the midfoot, because when the big toe moves, when the big toe extends during gait, the midfoot should stabilize reflectively. Because it's like a more common example, with lower back pain. People have lower back pain, and the therapist will say, activate your core when you're walking, whatever that means. How's that possible? Like, you've got a mum of two walking around the supermarket, running after 2 kids, trying to buy her groceries, and we're asking her to activate her core while she's doing that stuff. It's not going to work. However, if we mobilize the hips, mobilize the thoracic spine, reflectively, there's a neurogenic loop, that should happen subconsciously. And that's the way it should happen. And that's the way it will happen with a pain-free person, because it's reflective.
Yeah.
Like if you're consciously stabilizing all the time, it's very hard to do, very hard. But if you improve mobility, that gives the joints the awareness through mechanoreceptors, joint capsule receptors, etc., to like let the brain know where we are in space. So then the joints and the muscles will stabilize in and around that area.
Yeah. No. Perfectly explained. It's just because, as well, exactly, we look at so many different things, but we just forget about the little joints, which are so important.
And what you'll find actually with big toe, so someone comes in with a stiff toe. I don't know if you guys do a lot of gait assessments, walking assessments, but commonly what you'll find is they'll walk Charlie Chaplin style, toes turned out.
Yeah.
Because what they're trying to do, they're trying to avoid rolling over their toe, so they roll over the inside of the foot to avoid extension. But then that they're abusing the joint by joint theory. So then they're getting, so if you imagine someone's walking Charlie Chaplin style, they're rolling over the ball of the foot. So they're going to develop like medial foot pain, possibly bunion type order. They're sacrificing their stability in their midfoot because they're collapsing too fast. They're overpronating because they're not going through their toe. So now they've abused the joint by joint because they've lost mobility in their foot. So now they have to get mobility in their midfoot, which should be a stable joint. They've lost mobility in their ankle. They're walking on the inside of the foot. So now their knee is diving into a valgus collapse. They're knocking their knees. For sure, they've lost hip extension and rotation. So how are they walking? Probably using a lot of lumbar rotation to generate torque. So they flip-flopped from the joint by joint. So we can massage these people till we're blue in the face, but we have to start mobilizing the stiff joints. So toes, ankles, hips, thoracic, shoulders, upper C-spine, because that's just one abuse. Yeah. And that's from the bottom up. It can go from the top down too with the neck. If we lose upper C-spine, like C1, C2 mobility, which we, again, like we spoke about last week, the upper cross syndrome, someone with the upper cross syndrome, their head translate anteriorly. So the head and neck translate. So you're talking C7, C6, C5. They've lost stability of the lower neck. So then their upper C-spine, C1, C2, will have to become stiff. So they start walking with cranial extension on the neck. So again, they've lost the joint by joint, and now they're walking around with upper cross syndrome. But is it upper cross syndrome, or are they abusing the theory of joint by joint? It's both. They kind of live in the same world. They're kind of the same. They both represent and they both look the same. But the joint by joint is more looking at the articular, the joint movements. The joint
system,
But when we treat it, we don't separate because many neurological laws. If someone has a stiff ankle, the muscles going over the ankle and then around the ankle are not going to be working adequately because they're not getting the feedback from the joint because the joint is not moving. So the muscles don't know what to do because they're not getting the feedback loop from the ankle joint.
It just simplifies it. Everything is connected and working together.
Very much so, yeah.
Without explanation. So Dan, you tell us, you explain a couple of really good examples, and exactly we have mobility, stability. So what are the points of focus which we look at in the person when we are assessing them, and how we can measure that, how we can assess that, how we can get the idea, someone coming to see us for the session and, let's explain, we're going to do assessment now. Let's check your mobility, stability. What we doing?
Okay. So the way I do it in my practice, I use, and if they're coming in and they've got pain, which most people who come to see me...
Do you use this assessment tool all the time with every client?
Every client. Everyone who comes in, if you come in to me and say, hey, Danny, my big toe's hurting, you get the same. If your wife comes in and says, oh, my shoulder's hurting, she gets the same. The first initial screen is the same. Yeah. It's the same, regardless of, Most of the time it's the same.
Yeah.
Obviously, there's some difference. But so if someone comes in, we want to check the upper neck. So the way to check the mobility of the atlas axis, C1, C2, you have the client standing straight, standing up, feet together, relaxed posture, close the mouth, touch the teeth, but don't clench. They take a breath in, and can they touch their chin to the sternal notch? Can they touch their chin to the chest? That's assessing general neck mobility. Then we want to really go after the upper C-spine. It's the same standing posture, same mouth position, but this time they turn the head 45 degrees to the left, and can they touch their chin to their collarbone? Mm-hmm. And then obviously this is bilateral. We have them do that both sides.
Oh,
and what
tight.
you'll everyone feels one side tighter for sure. But what you'll find is, and you'll find this a lot, people either open their mouth so they touch their chin, or they shrug, or they just pull some really weird face, so that, and or they hold their breath.
Yeah.
So, and that's a big thing. Like,
I can see that usually when we check the rotation thoracic spine, they use her head to kind of pull them more.
Yeah. But like with the breath holding, like that's a sign of dysfunction.
Of the tension, yeah.
Yeah, like they're trying to. There's strategies. There's different types of strategies.
They're struggling. That's why they're holding the breath.
And they're trying to create stability.
Trying too hard, yeah.
They're trying to, because we have a diaphragm in our neck, like we have a diaphragm in our core. So by holding their breath, they're trying to create stability to move. Because the body
come back. Diaphragm in our neck.
We have a diaphragm here in our jaw. So if I go to touch my chin to my chest and I hold my breath and brace, I'm trying to create stability to create mobility. So the body will always sacrifice.
Okay. No, it's not like we have a diaphragm in our neck. It's just the expression which creates.
Well, no, it's a floor of muscle. Like we have a floor of muscle here, and like we have a floor of muscle here. Like we have a pelvic floor. They're all diaphragms.
Okay. Gotcha now.
It's not called a diaphragm, but they bow like a diaphragm.
Oh, yeah.
Like,
okay, I got you now, yeah.
So, like, the body will always sacrifice mobility for stability. So that you're always going to lose mobility for stability. That's why we see a lot of stiffness. And that's why when people hold their breath, they're trying to create stability to gain mobility.
Yeah.
But it's a bad strategy for that particular thing.
Oh, wow.
It's what they call a high threshold strategy for a low threshold task.
Yeah.
So if I said to you, Chris, pick up this pen, and you had to hold your breath to do it, that's bad. But I said, hey, Chris, pick up this 300-pound weight, and you hold your breath, Chris, that's great. Like to do something very easy, we don't need this crazy Valsalva, crazy stiffness to do it. And that's what we see all the time with our clients.
Yeah.
All the time.
Okay, so we had the neck stability, so the movement.
Yeah, so that's for the neck.
For the neck,
and there are a couple of others. There's one with extension, same thing. You want to keep your mouth closed, and you should be able to look towards the ceiling with your face pretty much parallel to the ceiling. Yeah. This is for thoracic extension. The next one is for the glenohumeral joint, the shoulder.
Yeah.
What you should find is, let's say with the right arm, you should be able to reach behind your back and contact your index finger, your nail of your index finger, with the inferior lateral angle of your scapula.
Easy. Okay.
Both sides.
Oh, shit. Oh, well, yeah. The left one. Yeah,
and
I can
the
do
same
it,
thing.
But, yeah.
And then you should be able to go above behind your head and contact the spine of the scapula and the spine of the scapula on the other side.
Okay. Oh, that's easy. That's fine.
With no pain.
Yeah.
And again, same rules apply here. You'll see people taking a big breath in. You'll see people.
Yeah, I was focusing. Yeah. Here you go. I did it. Yeah. I haven't even think, but well, this one's fine, and this one was like.
Yeah.
I was just holding. I didn't even think about it. Yeah. Oh, you just talked about it. Yeah, go on.
And what we'll find is with this as well, people will reach behind their back, and they'll contact like the lower back, and they'll inch their way up to cheat. It should be one fail swoop.
Yeah.
So one's looking at external rotation, one's looking at internal rotation. So this is checking internal and external rotation of the shoulder, but it's also looking at like it's called the scapulothoracic rhythm. Can we like create a nice rhythm of the arm, shoulder, thoracic area to reach back? Because this is not just a shoulder screen. It's a scapula. Can the scapula AB duct rotate? Can the thoracic spine extend? Because when we reach back here, it's extension. Most people can't. And again, like we spoke about last week, if someone's in a upper cross syndrome, so kyphosed, rounded shoulders, internally rotated humerus, you say, hey man, reach behind your back. They're in a really bad position. They probably ain't going to be able to do it because they're starting in a really bad position. Yeah. So that's when our soft tissue work comes in to get them in a good position to start. Then they might have some success. So these two theories or these two systems really overlap. That's what I really love about these two. So simple. Well, simple once you know it. It's not simple.
It's because it sounds like lots of information, but if you get into it and have a knowledge and actually see some stuff, like even videos or pictures, that's pretty straightforward. Yeah,
if you go onto their website, there's actually a bunch of free resources online.
For what website? The functional movement
systems. Yeah.
Okay.
A lot of free information.
Okay.
And then it goes down. So now we've looked at the neck, the shoulder, and then we got to look at the thoracic spine.
Yeah.
These are all mobile segments, or should be mobile segments. So the way I do it initially, it's a gross rotation. So you have the person standing up, hands across their chest, or actually hands by their side. Sorry, feet together, knees together, and they take a deep breath in. They breathe out, and they turn their whole body: head, shoulders, hips, knees, ankles. And you're just looking for gross rotation.
Okay.
So this doesn't really tell us if it's the thoracic spine. We're just looking at the gross ability to rotate. And again, you'll see people, they'll get cramp in their obliques. They'll extend through their lumbar spine. Again, they're abusing the joint by joint. They're extending where they shouldn't, as opposed to rotating where they should.
So, and how to check the mobility in a thoracic spine then?
So if someone does what I just described, they're standing up, they rotate, and let's say one side is okay, one side is not good. So we don't know what's not rotating. So if I ask you to rotate standing, so when I do it, I say, Chris, rotate head, shoulders, hips, rotate as much as you can, everything. If you can't do it to one side, we don't really know why yet. Is it your stiff neck? Is it your stiff thoracic? Is it you're lacking internal, external rotation of the hips? Mm-hmm. Do you have a tight superior fib joint? Are you lacking some ankle mobility? Yeah. So to isolate the thoracic spine, what I do was a couple of things I do. First thing I do, I'll sit you down. Sit down on the edge of the massage table with your knees touching, sitting up straight. Now rotate. If it's still bad, we've taken away the hips. We've taken away the knees. We've taken away the ankles. So now it could be lumbar, thoracic, and neck.
Yeah.
So now we've broke it down from upper body to lower body. And then as you go deeper into the assessment, then we chunk it down even more. And then we can devise, is it lower back?
Yeah.
Is it thoracic? But if they show a positive on the seated one, 8 times out of 10, it's probably a thoracic spine mobility restriction.
Problem. Yeah. Okay, so that's a thoracic lumbar spine.
Lumbar spine. We're not concerned about mobility.
Yeah, stability, isn't it?
That should be a stable segment.
Stability.
Contrary to thought processes probably, and contrary to treatment plans. In my world, when I see people working with people, they always want to stretch the lower back because it's what the client comes in for. Hey, my back hurts.
That's a problem. And usually because there is no mobility, what suffer? The stability.
Yeah. So,
okay. Yeah. So let's move on really quickly. So there is hips.
So
Mobility.
hips should be a bit of both, but mainly mobile. So the quickest and easiest way that I do it, I have the client prone, lying face down. Bend one knee at 90 degrees, anchor the hip, and move their hips into internal and external rotation. You're looking for about 40 to 45 both directions. And and we're talking left and right leg, obviously. What you'll commonly see is, let's say you check internal rotation on the left and they've only got 10, 15, say, they'll have a bunch the other way. So they only have 10 internally, they might have 60 or 70 externally. So they still got a gross of, say, 80 or 90, but it's all in one direction. And then what commonly happens, you check the opposite side and it flips, it's reverse. They have a bunch internally, but not a lot internally. So they've really got dysfunctional hips because they've got 2 bad hips, but 2 very different hips.
Yeah.
So that's the rotational element of the hip. Then you want to check hip extension. The way I do that, same position, prone, stabilize in and around like the inferior lateral angle, the bottom part of scapula, the bottom part of the sacrum.
Sacrum, yeah.
Grab the knee and just extend the hip. You're looking for about 20 degrees.
Okay.
Bilaterally. Or you can do a Thomas test. Do you guys use a Thomas test?
Yeah.
Or use the Thomas test. I like the Thomas test actually because I like to show the client.
Yeah. Because clients, it's much easier to than on a. This is active test which you can use it prone, but Thomas test is more visual and more, but for the clients as well.
And then you do the hamstring, so the posterior chain. I'll do a straight leg raise.
Yeah.
And or a long toe sit. So a long toe sit is the person sitting on their butt. They put their legs straight and they reach towards their feet and they want to touch their toes.
Yeah.
And then with that test, actually though, let's say you can touch your toes and so you're good, but you're not quite good yet. We need to check the sacral angle because what sometimes happens is someone can touch their toes, but it's coming a lot from their ability to kyphose and abduct their scapula. And if you check the lower back, the sacrum needs to be about an 80-degree angle. So if the sacrum still flip back, it means they're not unlocking their hips and moving from the posterior chain. So we're talking like hamstrings, calves, hips. Yeah. They're moving from like the upper back. So if you do the long sit, always check the sacral angle at the back because it can trick us.
Yeah.
Don't be tricked.
Don't be tricked. Clients cheat.
Yeah.
Clients cheat. That's it. Yeah.
And we do too.
Yeah.
We do too.
So that's the knees and angle mobility is obviously dorsiflexion, plantar flexion, inversion, eversion. Yeah,
dorsiflexion is the key one. Because I don't know many people say, "Hey man, my ankles are really loose." People think they're loose because they've had an ankle sprain, but they're actually probably really stiff because they've not got any stability in their midfoot.
Yeah.
So not many people have like excessive dorsiflexion. You might get a few freaks out there, but not many.
Yeah. No, I definitely have like lots of plantar flexion, but no dorsiflexion. I mean, it's crazy. Yeah. Okay.
Need to work on that.
I know. And obviously, don't forget about the big toe, and just check the mobility of the big toe as well. So, okay, lots of tests. We have a concept. We have what to check for and how. So, the assessment. The measurements. So we have some information. So how do we apply this in our session? How do we treat the clients? What should we focus? How we explain that to the clients? What should be our main point of focus?
So what I say, if I've got a client come in and I've never seen them before and they come in with a bad back and I start looking at their neck, their shoulders, their ankles, and I'm like, hey man, it's my back. That actually doesn't happen that much anymore. But what I'd say I'm trying to get a blueprint of just a general way you move. I'm not really focusing on your back right now. I just want to see how you move through life. And then I'll briefly explain, if needed, why we need to take this holistic approach. So I talk about how, what we spoke about today. If you've got a stiff hip, your back has to do too much. If you've got a stiff chest, thoracic spine, your shoulders need to do too much, and it's not their job. So like you're putting too much emphasis or too much work on the lower back, and your lower back is not designed for a bunch of mobility. It's designed to be relatively stiff. There's not a lot of rotation in the lower back, actually. I think the research says it's like 2 to 5 degrees, so it's not a lot. But we need to get it from above and below. So yeah, I'll just explain. This is a snapshot. We're trying to see how you move, how you compensate, where you're good, where you're bad, and we're looking for asymmetries.
Okay.
Yeah, so most clients actually are pretty receptive to that. It's just like the analogy I use is like we're just checking, we're just seeing. Like if you went to the doctor and you said, "Hey man, I feel a bit funny like in my chest," and he goes, "Yeah, your blood pressure's probably high." Okay, check. It takes 2 minutes. You want to know, like so. Sometimes we assume that the person's got stiff hips or mobile hips or whatever. We should just check, and it doesn't take much time. Like rather than always be guessing, we can just check real quick, and then the assessment becomes a treatment anyway.
Yeah. And obviously the golden rules, which I think is one of the best advices and golden rules in a therapy business, who get referral and come back clients. When you check it, retest it after, show the clients the difference.
Exactly. And you could do you mean recheck within the session? Is that what you mean?
Yeah. After the session.
Yeah. And then recheck when they come back next week.
Yeah.
If they get better, great. Then that's a referral source. And
if they don't,
don't retest. No, I'm joking. No, but like that happens to me commonly.
Yeah.
So I'll mobilize someone's hips. I'll do all the stuff I do. I'll check their movement. It didn't improve that much. So then I'm thinking, I might have to do a bit more stability training in their core, for much of a better word. So we'll do some core work, some reflective stability work, then recheck the hips, and it's okay.
Yeah.
So sometimes that's the good thing about doing both. You can dose it in, because sometimes the soft tissue stuff won't work, and sometimes the exercise stuff won't work.
Yeah, and it is,
and that's okay. That's okay.
And that's okay. And many times, some people reacting to the treatment very, very easy and very quickly. Some people, they don't, and they need a couple of more sessions. Their tissue responding completely different. Their nervous system work completely different. Their lifestyle is completely different. So when something don't work straight away, don't think that's something bad.
And also, it's like sometimes we think like, what do we mean by didn't work? Like, if someone's got a super short hamstring, like we can't really get that hamstring to lengthen. It's going to take time. Like the said principle, like specific adaptations to impose demands. If that muscle is truly tight, it doesn't get loose after 20 minutes of PNF, because it just can't. Maybe if there's some neurological tightness, yes. If there's some instability in the hips, yes, it can improve. But then you need to improve it in the new ranges, because if you don't, the body's very smart. It's metabolically very frugal. It's not going to allow us all this new elaborate range if we don't use it.
Yeah.
So if we mobilize someone's hips, you say, yeah, you're good, go away, and they don't start using this new range, within a day or two, it's going to go back.
Yeah. So
that's why, and again, maybe we can talk about this another time. I talk about a lot about rest postures, positions of repose, because I know in the US, if someone's just purely a licensed massage therapist, there's a lot of rules around about exercises and stuff.
Yeah,
I'm
I
not. I don't know how it is in England right now. I've not been there for so long.
More freely here.
But what I do now, or what I tell my people who've done my trainings with massage, to educate clients on positions of rest. Like I think we spoke about it last week briefly, and that's huge. You can just put someone in a rest position. They don't even know, but they're mobilizing their hips and stabilizing their core. But all they're doing is watching TV in a certain posture, and that's how you get the work we do in the clinic to stay around longer, because they're using that new mobility as opposed to just not using it, and they're going to migrate back to where they were.
So basically teaching clients how to use the life habits in their positive life, so the work we do in a session, they can take out their life and reuse it. So basically, we're teaching them how to sit, how to lie, how to be.
Use it or lose it, right?
Yeah.
Like I've got a client here in Miami. I see him like twice a week. Great guy, bad client. But he'll he doesn't like doing homework. He doesn't like doing anything. And he is stiff as a board.
Yeah.
He is probably one of the stiffest humans I've ever encountered.
Yeah.
I said, hey, bro, you need to like do this. He's like, I won't do it. I said, okay, that's okay. But we're not going to get you where you want to be.
Yeah.
Seeing me 2 hours a week, we ain't going to get where you want to go that quick, because you sit down 15 hours a day. Like, we're pissing in the wind, so to speak. Like, you sit down all day, you see me for an hour, we stretch, we do our stuff, and we do great stuff, and you improve. But then you sit down for 5 days, I see you again, and you're back to kind of where you are. Yes, you've got a little bit less pain. Yes, your tissue tension's a little bit better. Yes, you move a little bit better, but you're still really stiff. And you always be really stiff unless you change your habits. Yeah. But he won't, and that's okay. So I know where I stand. He knows where he stands. Yeah. And we're just sort of like we're trying to make him not get any worse. Yeah.
Yeah, because it's really hard to make clients unless they're really motivated to make them do stuff. Of course. And we can't make them do anything. We can make them. We can't just live with them for 6 months and just kind of do stuff and help them out. It's just they have to be always their choice, and obviously everyone have a different life habits and patterns and so on, and we can advise them and help them as much as we can, but it's in the end all about up to them.
But the reason why I brought this guy up, like I wanted him to do exercises.
Yeah.
And he wouldn't. He just don't like the gym, and that's okay. So then I said, okay, do these 2 rest positions. So we gave him the rest postures, and he's doing them. And he's like, man, my back doesn't hurt as much. I'm like, oh, no shit. Like,
yeah.
I'm like, you sound surprised. I've been telling you this for 6 months. But I'm trying to get him to do more. But he's doing the rest postures, which is lengthening out his hamstrings and hips and for his thoracic spine. So yeah, that's just one way of segueing away and around to get people to do what we think they should do, without putting them in like that real sterile, or what some people perceive to be a sterile gym environment. I mean, I like the gym personally, but I know a lot of people don't.
Okay, another question, which kind of obviously is kind of gentle. Obviously, everything is a bit more different to point. How this testing and the stability, mobility, in assessing how that's going to work with someone who have, like, let's say, hip or shoulder replacement. Obviously they recovered, they fine, but obviously there is how's that applying to people who have a joints replacement?
Obviously you got to be careful, and I'd probably get some sort of like information from their primary or their surgeon, because I know with hip replacements you've got to be careful with combined movements, like uncoupled movements. So if you're, say, abducting the leg, you've got to be careful with certain rotations. Yeah. Same with shoulders. If you're adducting and rotating, you've got to be careful. However, if they still need a certain amount of mobility in that replaced joint, and they still need the stability and the mobility in the joints above and below. So if someone's got a joint replacement of the shoulder, say, which is a big deal, I would assume they've got a bad T-spine. I would assume they've got a really unstable scapula. So maybe go after the other stuff to take the pressure off. Because sometimes, like, when you see people they have winged scapula.
Yeah.
You've seen that a lot, or their scapula's way stuck out around the side of their ribs. People think, they've got a really mobile scapula. They haven't. Their scapula's stuck in a position. It's lacking movement and stability. It's stuck. The scapula should be very it should move a lot in a lot of different directions. It should to accommodate thoracic movement and shoulder movement. So yeah, with replacements, I would probably look at the joint by joint as it relates to the joints above and below, and maybe get some guidance from maybe.
And that's why I'm asking, because you exactly perfectly explain. Don't focus on the bad area. Don't focus on the problem area. The complaining people, because if you go below and above, you're gonna help.
For sure.
Enormously in other things. Sometimes don't obviously pay attention and do some work around it. But if you're gonna focus on the things around above, you're gonna do better help than actually doing some a lot of work in the let's say lower back, as is common complaint. If we just
And
focus on a lower back, we're not going to do much.
And it's crazy, like hip replacements now. I read a stat somewhere regarding the amount of hip surgeries in the US, and it's insane. It's gone through the roof. Why is that? I don't know. I mean, I'm gonna assume most hips they're lacking something somewhere, and that's why they're getting the replacements. I've got a client. He's probably 42, 43. He had a bilateral hip replacement. He had anteversed hips. He had no rotation. And he was a great athlete. I'm like, wow, how the hell was you a great athlete? But he was stiff as a board, and he was a sprinter. And he has bilateral hip replacements now. But he's fine. He's doing really, really, really well. But so yeah, just be careful with that stuff. Would be my suggestion.
No, so guys, Danny, thank you again. You just really explained. I think our listeners really benefit from all the information we had today and take out some of it. Obviously, I will definitely recommend check this episode on YouTube, because you will see us and what we're showing lots of things, and we test and stuff, so you will see better than just listening on the podcast. But yeah, definitely go check it out. The joint by joint theory. We're going to put lots of links in the below. Go check it out. Functional movement. What's it called? Functional movement systems. Functional movement system, which explain you all the test exercise and what to look at and what to look for. And if you just have a read, focus, take some part, and kind of try some of the things with the every client next time will come, and kind of obviously it will come everything with the experience, so you have to test, do it. Danny, after years of experience doing it every day with every client, now he have a better understanding, and now with the 5 minutes of looking at the personal movement, he can explain and do a lot. And that is all for the benefits of the clients, your benefits, to make them better, to make them come back, to make them feel great.
My thing to listen would be, if you're going to do anything, check ankles for mobility, check hips for mobility, check thoracic spine for mobility, and check neck. If they're the only things you check those. If you mobilize those, the segments above and below reflectively stabilize. That's a given. It's called reciprocal innervation. If you mobilize the stiffness, the weakness improves.
Yeah.
And you can't get an area strong if it's stiff. So you need to mobilize, stabilize, activate. So you need to mobilize those 4 areas I just described.
Mobilize, stabilize, activate. Perfect. Danny, how we can connect with you online?
I have an Instagram account. It's Pain Posture Performance. I've been posting a bunch of videos there. I'm going to be posting more next week. I have a Facebook group, same name, Pain Posture Performance. I have a website, Pain Posture Performance. You see it? There's a theme here, right?
I wouldn't guess. No, come on.
Yeah. So that's the best way. Instagram, Facebook, and my website. My website's in the process of being more updated, actually.
Oh, awesome.
As we speak.
Okay. As I always said, we're going to put all the links below so you can check it out, all the information about Danny, ask him questions, follow him, because it's pretty cool, lots of cool videos showing lots of tests, lots of movements, lots of treatment stuff. Which
if people have questions, if they send questions into you or me, I'll gladly come back and do a Q&A if people want that.
Oh, brilliant. Amazing. And I truly believe we're gonna, Danny, have you more on the podcast, because you have amazing knowledge and definitely bring lots of information, inspiration for our listeners. Danny, thank you very much for joining me today. Have an amazing day. Thank you for doing it, and speak to you soon.
Pleasure. Take care. Thank you.
Cheers. Bye
bye.